over 75% of gender dysphoric children would accept their biological sex by young adulthood. Now, within there, they would come to accept their biological sex by young adulthood. 60% of those who resolved would identify as lesbian, gay, or bisexual. So this is why there is a debate within the LGBT community about making gender dysphoria a medical, taking a medical approach to gender dysphoria in young children. So there's actually common ground in terms of concern for children. The Diagnostic and Statistical Manual of Mental Disorders, DSM-5. So the top one is basically the Bible of the American Psychological Association. The DSM-5 is, quote unquote, the Bible of the American Psychiatric Association. On page 455, says that as few as 2.2% of gender dysphoric boys will persist and take a trans identity. So in this particular reference book, it says, let's say 97% of gender dysphoric boys will resolve. And from the calculation, they say as few as 12% of girls may identify as trans, so meaning as many as 88% of gender dysphoric girls will resolve. With those high statistics of resolution, and these are kids who there was either a watchful waiting approach or a supportive therapy approach that would support them through puberty. Obviously, the vast majority of these children were not committing suicide. Now, those who favor the medical model insist that those statistics are flawed, that the studies were flawed. That objection has been rebutted by Dr. Devita Singh in 2012. Her dissertation, she analyzed data from the Toronto clinic under Dr. Zucker and Bradley and confirmed an 88% success rate. Dr. Steensma justified his findings around 80%. And then Dr. Ken Zucker, more recently, last February at the US PATH conference, the US Professional Association for Transgender Health, also reviewed his data and confirmed an 88% desistance rate. So what to make? Suicide, we take every threat of suicide seriously, but is it true that children's only choice is to transition or commit suicide? Well, as I said, in the past, when there was either a watchful waiting approach or support them through natural puberty, the majority did not commit suicide. We also know that among adults and children, those who do complete suicide, over 90% of victims do have a diagnosed mental disorder. We have no reason to believe that children with gender dysphoria who commit suicide are any different. So therefore, it is very plausible that the best way to prevent suicide in children with gender dysphoria is not with hormones or surgery, but the same way we would prevent suicide in anyone else, by better psychiatric therapy, better treatment of their depression and anxiety. These are comments by two psychologists who are experts in the treatment of adult transgenderism, who are very concerned about the medicalization of gender dysphoria in children. And in their analysis of the suicide data, they have published there's no persuasive evidence that gender transition reduces gender dysphoric children's likelihood of killing themselves. And the idea that mental health problems, including suicide, are caused by gender dysphoria rather than the other way around is unproven. So in other words, it could be, as I suggested before in other examples, that gender dysphoria is an adaptation. It's a response to mental health problems, depression, anxiety, which are being caused maybe by things going on in the child's life, whether it's family, whether it's abuse at the hands of a stranger, peer experiences. That is a possibility. What do we make of puberty blockers? The puberty blockers are not FDA approved for gender dysphoria. They are approved for use in children for precocious puberty. So if you're a child who's going through puberty, let's say at age 5, that is disease. It would be damaging to allow the child to go through puberty at age 5. So it is appropriate to put the child on Lupron. The child who was going to have puberty at age 5 goes on Lupron, is then taken off the Lupron around age 10 or 11, and will go through puberty at age 12, as an example. That has been studied, that is approved. Lupron is also approved for the treatment of prostate cancer in men, endometriosis in women. So what are the potential side effects? Young men who were treated for precocious puberty as boys, I say potential side effects because there is some evidence that it may cause obesity and testicular cancer in those men treated for precocious puberty as boys. It may also be responsible for brittle bones and severe osteoporosis in women who were treated for precocious puberty as girls. It's also been associated with cognitive decline in men and women who have been treated for prostate cancer and endometriosis. Now, so the potential side effects are real. These are not typically discussed with parents who have a child with gender dysphoria. Parents are told that the puberty blocker is totally reversible. Now, it is true, if you put the child on Lupron and next week the child says, you know what, this is crazy, just take me off. All right, yeah, no harm done. His body, his regular, his pituitary glands, et cetera, will kick in, his own cycles will return. But if that child stays on the puberty blocker for a few years and then changes his mind, you can't give that child the years that he lost. You can't give those years back in normal development. So even though his own system will kick back in, you really have robbed him of normal pubertal development time, both physically and psychosocially, emotionally. Now, as far as the research, there's only been one long-term study of 70 children, and 100% of those children who were so 70 kids put on puberty blockers, followed out to their mid-teens. 100% of them went on to request sex change hormones and claim a transgender identity. So the concern there is, all right, before we medicated kids, they thought they were transgender. Well, over 75%, over 80% would say, come and resolve and identify with their sex. But now we've put them on puberty blockers, and in this study, 100% reject their sex. Are we preventing them from resolving the gender dysphoria? That's the question. So from puberty blockers to cross-sex hormones, this would be if you are a biological male and you feel like a woman and you want to transition. If you're a man, you're given estrogen to transition to appear more female. So estrogen is the cross-sex hormone for men, testosterone is the cross-sex hormone for women. This evaluation, and here I'm talking about adult transgender patients, This evaluation was conducted by Hayes Incorporated, which is hired specifically to research medical technologies. They have no stake in this, so to speak. Their job is to give an unbiased, what does the research say? So looking at the adult research for cross-sex hormones, this company said improvements are not consistently demonstrated by multiple studies for most outcomes. So while, yes, there are individual transgender adults who say they feel better, and they're not lying. We can believe them, they feel better. But if we want to be scientific and look at the studies and the evidence, the studies are not well done. The science does not bear it out. Evidence for improved quality of life and function in male to female adults was very sparse. There are significant long-term safety risks. So what are the safety risks with cross-sex hormones? We know that they change your body so that you're more at risk for stroke, heart attack, high blood pressure, diabetes, potentially some cancers. The studies in adults that have looked at this are very small. They're so small and they're also short-term that these safety risks, which are potentially very real, I mean, they're real risks, but because of the study's design, have not been proven, but they've also not been conclusively ruled out. So when you're giving a patient informed consent, you should tell them this medication, this lifelong medication that you are going on to appear more like the opposite sex may be putting you at risk for heart attacks, high blood pressure, cancer, diabetes, etc. Now, this company in 2014 analyzed adults and then all of the evidence for children. And for reference, the United States has been treating children medically since 2007, beginning at Boston Children's Hospital. This report came out in 2014. So over the course of 7 years, there was absolutely no evidence base for safety or efficacy in children with gender dysphoria. But from the beginning, in 2007, families going to Boston Children's, and now virtually any pediatric hospital you walk into, families are being told, this is safe, this is effective. It's not true. What's not true is that if doctors or anyone says, we have the scientific evidence that this is safe and effective, that is not true. And the top reference is actually the Endocrine Society Clinical Practice Guidelines for treating gender dysphoria. Within those guidelines, they rate each of the steps in terms of level of scientific evidence. Out of the 22 steps, only 2 of the 22 steps they identify are based on moderate evidence. The 2 steps based on moderate scientific evidence have to do with monitoring for serious health risks from the medications. The remaining steps, including social affirmation, putting them on puberty blockers, etc., are based on either low evidence or very low evidence. And that's rated by the Endocrine Society right within their practice guideline. And that was 2017, and the study beneath it similarly concluded that it's still not evidence-based. This is an experiment that's just going on full bore on our children right now. Sarah Hall, whom you beat, were recorded in both USA Today as well as the Hartford Courant. Sarah Hall said, I can't really say what I want to say, but there's not much I can do about it. It's frustrating, but that's just the way it is now. Now you can find this online. It is posted at fourthwavenow.com, which is a community of left-leaning parents and others who are deeply concerned about the medicalization of gender dysphoria in children. So how is teaching children in school that they might be trapped in the wrong body, how is it dangerous? Again, it could derail their cognitive, psychosocial development. Social and medical transition may be locking children into their gender dysphoria that they otherwise would have outgrown. And one side effect I did not discuss earlier, if you put a young child, let's say between the ages of 9 and 12, on puberty blockers, and then follow this up with the cross-sex hormones, those children are now permanently sterile because their testes and their ovaries never fully matured. And if they never matured, then there's not enough tissue to freeze, let's say for artificial reproductive technology down the line. And I mention that because I've been writing about the sterility, and folks one physician on the other side wrote back, oh, you're lying, kids can just freeze their tissue. No. If the child has gone on a puberty blocker before fully completing puberty, before that full maturation, and then goes on a cross-sex hormone, that child will not have any mature reproductive tissue to freeze. We covered double mastectomies. So this after transition adult transgender suicides became, it says 19 times greater, so I'll explain more there. There is a Swedish study that was completed a couple years ago. It followed over 300 adult transgenders for 30 years following their sex reassignment surgeries and hormones. Initially, most of the adults expressed being pleased, relieved, happy. By the time they got 10 years out from surgery, their rates of anxiety and depression were definitely elevated above the general population. By the time they were 30 years out from surgery and hormones, their suicide rate was 19 times greater than the general population. So what might this mean? The authors of the study concluded this means, and these are the authors who are transgender affirming. The authors of the study said this means that surgery and hormones are not sufficient treatment for gender dysphoria. We have to improve the psychological care afterwards, after the transition. What might this mean for the children who are undergoing the transitions now? It means that if we really want to know whether or not this is safe for them, that we may not see the final repercussions until 10, 20, 30 years from now. And then I think the last line is rather obvious, that if merely believing that you are a boy or a man is sufficient to make you a boy or a man, and you want to compete, so you're a biological woman, and you feel and think you are a man, and want to live as a man and compete with men, even though you're on testosterone, you are still physically at greater risk if you're competing with them, on top of the fact that you're being exposed to all of the side effects from the testosterone. Similarly, if you are a boy and all you have to do is think and feel that you are a girl and claim so, and not even undergo any hormone changes or surgeries, you still have your intrinsic testosterone even if you are taking estrogen as a boy. You have an unfair advantage over those girls. We can't change your sex. Women's sports are for women, men's sports are for men. It doesn't matter what hormones you're taking, it doesn't change your chromosomes. and that used to be called doping. So we absolutely do need to promote respect for everyone, including children and adults who break sex stereotypes. That's easy to agree on. Just because you behave differently, speak differently, does not give anyone the right to ridicule you, harass you, or hurt you. But when it comes to teaching in school, our children need to be taught the truth. They need to be taught biology, not gender ideology. And this last picture book here is available online for young children, preschool, kindergarten, and it basically teaches that girls have 2 X chromosomes, boys